thousands of years ago described concussion. It was thought to occur because of traceless disturbances. They didn't understand it, they couldn't see it. The patient actually looked normal. That hasn't changed whatsoever. And concussion was thought to be mostly benign because most people recovered from it very nicely, and that's still true today, up to 95%. But what was interesting, I think, was that at the time that all this was initially being researched and thought about, there was also the birth of psychodynamic psychology and psychiatry. And there was a huge emphasis by neurologists who led that effort to start that type of thinking that concussion may not be really a medical condition, but may actually be a psychological condition. And thus, it was sort of started down that path of looking at this mostly benign, traceless disturbance where the patient looked normal, but maybe wasn't. So the Center for Disease Control defines concussion as an injury to the head, result of blunt trauma, acceleration, deceleration forces that result in one or more of any of the following symptoms. And you see the list of symptoms there: confusion, disorientation, any impaired consciousness, and so forth. Or observe signs of neurological dysfunction, such as headache, dizziness, irritability, and so forth. Yesterday, Dr. Hayes Alessandro mentioned in her talk on neuropsychology about loss of consciousness, and particularly about post-traumatic amnesia. But one of the key takeaways is that loss of consciousness occurs in less than 10% of concussive injuries. You don't need to have a loss of consciousness to have had a concussion. In 2007, Alan Roper published in the New England Journal of Medicine that you needed to have a loss of consciousness to have a concussion. This was very unfortunate in my view because it led a whole group of people down the line to question a diagnosis of concussion when it really occurred. It was clearly wrong, and serves as a great example for us to, even in the most prestigious of medical journals, to ask questions and don't believe everything that you read. Post-traumatic amnesia, we talked about that yesterday a little bit. Anterograde amnesia occurring after the injury occurs in 25 to 30% of cases. Retrograde amnesia can occur, and when that happens, it's probably a little bit more problematic for the patient to recover. In Zurich, Switzerland, every several years, there is a group of people that get together and form a consensus about concussion. The most recent was in 2013, published in the British Medical Journal. And their definition is concussion is caused by either a direct blow to the head or face or neck or blow elsewhere on the body. And so they were of the impression that any decelerative or accelerative force may produce a concussive injury, even though it didn't apply directly to the head. And it's a rapid onset, short-lived impairment, usually recovering, as you'll see, in about a week in most cases. And there may be neuropathological changes, but we really can't see those, and therefore it's more of a functional or physiologic disturbance rather than a structural injury that we can at least appreciate using conventional imaging techniques today. And there's a graded set of symptoms that may or may not involve that loss of consciousness. These symptoms tend to resolve in a sequential way. Like I said, most recover in 7 to 10 days. In children and adolescents, the recovery may take longer, That may be because of the fact that their brains are still immature and not fully formed, as well as the fact that they may have different kinds of blood flow, autoregulation, repair going on, and things of that nature. But there's no standard or there's no abnormality in standard structural imaging like CAT scans or conventional MRI. Here's a list of symptoms. I think you're all pretty well aware of it. It's best to have a baseline of the student athlete before the season begins. If at all possible, the trainers and coaches at the schools hopefully do some type of baseline assessment. They can measure their balance. They can measure some cognitive functions, such as using other kinds of computerized cognitive testing that may take 20 or 30 minutes. They can do a baseline assessment of various types that you'll see by myself and others that will talk here today about mild traumatic brain injury, so that you have that baseline and then you can compare it to a new injury and see, are they the same, have they recovered? What do you think a student athlete is going to tell you when they want to go back in the game? I'm fine, Doc, send me back in. Helmets. This goes, at the Helmet Safety Institute, hold still. Helmets do not protect against concussion. They protect against skull fracture, but not concussion. And the reason they don't is that concussion occurs as a result of an angular velocity applied to the brain that disrupts the connections and causes shearing of axons and nerve cells in the brain. Now the brain is made up of all different parts, and most of you know these kinds of things. The frontal lobe is what distinguishes us in many ways from our primate ancestors. Problem solving, spontaneity, memory, language, motivation, judgment, impulse control. Our teenagers do not have fully developed frontal lobes, and therefore we wait for that and hope that they don't do something stupid until their frontal lobes are fully formed. We've all experienced that, anybody that has children. The temporal lobe is behavior, emotion, perception, also memory, short-term memory in particular. Also some area of language. The parietal lobe is language on the left side of the brain in most patients, as well as sensory perception. And then there's the limbic system, the internal structure of the brain, a very fascinating set of connections that have very much to do with emotional control and all those different structures. And then there's the male brain. Now, I didn't put the female brain up here because I know I wouldn't make it out of here had I done that. But I want to draw your attention to the bottom footnote. The listening to children cry in the middle of the night gland is not shown due to its small and underdeveloped nature, best viewed under a microscope. So this is a movie, you can start it, Charles, that was given to me with permission by Kit Parker from Harvard Engineering. Kit has spoken a couple of times at this conference in the past, and it's a demonstration of the wave of energy that can go through, this is Jell-O, but which is very similar in some ways of consistency to the brain. And we'll play it one more time, but I want you to notice this is slow motion. This entire activity occurred in 125 milliseconds. Let's go do it one more time. And the entire mass of Jell-O is affected, not just the part that was hit. The force is transmitted all the way through. And when engineers study those forces and they look at where they go in the brain, in the upper left of this, you can see the pink part is right over here is where the hit occurs, where the highest positive pressure is, and then the wave is transmitted all the way to the back where there's finally a negative pressure at the back. And so that wave goes all the way through, and then the brain, it could recoil in the opposite direction. But look down below. This is also modeling of where the forces are transmitted internally. And it's transmitted right back to the limbic system. Are all the limbic structures in this area. So that, is it a surprise that patients who are, and I submit this to you just as a question, really, as a hypothesis. Is it a surprise that we see so much emotional difficulties in patients with concussion? And is it correct that we ascribe that primarily to their reaction to their injury? I just submit that as a hypothesis, and I have no idea how we solve that problem of distinguishing that. But it worries me that we are either overestimating or underestimating the effects of the concussion on the individual, especially in children. So this is a little movie, let's get that started, that I put together with John Alessi and Chris Alessi, who are graphic artists. And it shows that initial concussive injury, and it goes down to that nerve cell that's an axon and a nerve cell body, and you see a shearing effect that's occurring there. Here it is again, and you can either see shearing or you can either see stretching. And what happens is that those nerve cells then begin to have malfunction. There are little tubules inside the nerve cells that transmit nutrients down to the synaptic terminals. There's a delayed potential degeneration of that nerve, and it may take some time for all that to occur. And you may end up with nerve cells that are damaged or die in the process, especially in more severe injuries. So what are those typical locations for axonal injury? They're in areas where the nerve cell bodies and the axons take off. So right at that junction, cortical white matter junction, gray-white junction, or in the corpus callosum, the center part of the brain, or in the brain stem, or other areas, the white matter. So now what happens biochemically? And there's a number of studies now that have really looked at that. There is Dr. Giza in UCLA, who's done a lot of research and updated that research most recently. And it's thought that there is a complex metabolic cascade of change that occurs over a period of hours and days in an individual that disturbs that delicate neuronal balance that's occurring all the time. There's release of neurotransmitters. There's influx and outflux of various different types of chemicals and ions in the nerve cell itself that may cause toxicity to that cell. That metabolic disturbance can now be picked up using proton magnetic resonance imaging, what we call spectroscopy, where we can look and see chemical differences in the brain using very advanced MRI imaging. I'll show you some of that in a moment. So here's a little cartoon from Giza that looks at this cascade of events in mild traumatic brain injury or concussion that involves calcium rushing in, potassium rushing out, disruption in energy production, ADP to ATP in the mitochondria, and the loss of energy in that particular neuron, creating that energy crisis that can then lead to other problems such as some neuronal death, There can be shearing of the axon. There can be altered neurotransmission from one nerve cell to the next. And that neurometabolic cascade is thought to last up to about 7 days, and then it recovers. At least the neurometabolic cascade appears to recover. Maybe not everything, and this is all we can really measure at the current time. But you see that potassium and calcium curves there. Those are pretty much back to normal by about 3 to 4 days. But there's a reduction in glucose, that is the energy, sugar energy in the brain, that can last up to a week, as well as blood flow that can last up to a week. And if there is repeated injury, we now know that these processes even take longer to recover. And ultimately it can lead to chronic pathophysiology, and in particular, inflammatory things can begin to occur that begin to accumulate either inside the cell or outside the cell that then may affect other neurons in the vicinity. So sometimes, I don't know if you've ever seen this, I have, patients will say, I have my concussion, and classically we were all taught, when you get a brain injury, boom, that's it, and then you start recovering. It's just a matter of time. But in actuality, what can happen in a lot of patients is that they can have some initial problems that then get worse over a period of a few days. And that may be related to these inflammatory problems that can occur post-injury. And what are these metabolic disturbances responsible for from a clinical perspective? And this is hypothetical, but we think that that ionic flux that occurs initially is responsible for the migraine that people have, that have photophobia and phonophobia. The energy crisis certainly makes you vulnerable to a second injury. A axonal injury, as well as impaired neurotransmission, makes processing of information more difficult, impaired cognition, slower reaction times. And then finally, activation of certain things within the cells called proteases, which chew up proteins and put them back to their basic amino acid constituents. That may cause cell death, ultimately, if it happens severe enough. So, good news is, however, is that the natural history of concussion is good in most cases. It's variable. Some people take longer than others. Children, as I had said, tend to take longer than adults. Most symptom sports-related concussions, there's been a number of studies, including an NCAA study, resolve in 7 to 10 days. The role of rest, very interesting topic. So I have been personally all over the map on this one. I think when I started my career, we just said, you rest a day or two, and then if you're feeling okay, you go back. Then we went to the opposite extreme, which is you lock yourself in a dark, quiet room. In the teenager, you take away their video games, their cell phones, their everything that, television, and you go into a dark, quiet room and don't come out until you feel better. Try that with a teenager. Let me know how it works. And however, there's a recent study, really interesting study in 2015 in the Journal of Pediatrics, where they took 2 groups of patients, and in one group they did the absolute extreme, avoid all stimulation, and then they took another group which they dealt with in a more sort of unconventional, if you want to call it that, but normal way, where they said, you're feeling okay, just go back when you're feeling okay. And it turns out that the group that had the intervention where they were more confined did worse than the group that was allowed to have some activity. So this has caused me to now swing back into the middle, which is, sort of where we probably ought to be, which is use your best judgment until something better comes along. in terms of when that patient goes back. So now there's an advanced neuroimaging. And this has changed the way I look at mild TBI. Before, we had no markers, biomarkers, to look at, was there a structural problem? Are there physiologic issues? We had nothing, no way to know what was going on. But now with advanced neuroimaging, high field strength, 3 Tesla or higher MRI, and other things that I'll show you in a moment, we can see that changes do occur. So MRI and CT normally are unremarkable in concussion. But sometimes if the radiologists know that you're looking for head injury, that's very important when for you physicians or nurse practitioners or PAs, when you do order an MRI for head injury, you want to say it's for head injury, not for headache. They could have a headache related to their injury, but you want to say head injury because what you want is for them to do what they call a susceptibility weighted image, looking for blood products, hemosiderin, iron, the constituent of hemoglobin, that remains in the brain forever after an injury and can be seen. You know, iron is susceptible to a magnetic environment. And that's why they call this particular sequence a susceptibility weighted image, because it looks for the iron particularly. And when you see that, you know that there's been some bleeding at some point in the brain. And that could give you a clue that maybe those symptoms and problems in that particular individual are more profound than otherwise you would have thought. Also, using high field strength MRI, you can do what we call diffusion tensor imaging, and you can also do spectroscopy, also known as fractional anisotropy, to look at the integrity of fiber tracts within the brain. Remember, I talked about shearing injury and how nerve connections can be disrupted. We can now see that with DTI imaging, diffusion tensor imaging, and we can also look at the chemical characteristic of the brain using spectroscopy or FA, that fractional anisotropy, to look to see are there changes and shifts in the chemistry of the brain. So here's an example of a patient. The upper left is a patient that had conventional MRI imaging and it looks completely normal. And on the upper right, I'm going to just point you to some black dots. This is the susceptibility weighted image looking for that iron-containing hemosiderin blood product. And this particular patient has it in several locations. Here it is in the frontal lobe on the right side. Here it is on the left side. It's a little bit further back as well. So conventional MRI missed it. Susceptibility weighted imaging picked it up. Then, coming down here to the lower right, this is a color illustration of diffusion tensor imaging. And what you see here in a normal situation are all these nice sort of phalanges coming off the middle of the brain. This is the corpus callosum. And it should be sort of uniform the whole way, but what you see here is a loss of fiber integrity in the frontal lobe on the DTI image. And then, I'm not sure you can see that in the way it projects, but, oops, let's go back. You have, this is the fractional anisotropy or spectroscopy image, and what you see here is this big spike in the middle, and this is an indication that the chemistry is not normal. They measured two compounds in particular. One is called NAA, N-acetyl aspartic acid, and the other one is called choline. And when you look at this and you measure the choline peaks and the NAA peaks and you look at the ratio of those, and when there's neuronal loss or there's damage in brain cells, those ratios begin to shift, and the radiologist can tell us whether or not there is a chemical imbalance or not. And what I like to do is I look at all of these things. I don't look at any one in particular. I look at all of the data and I try to make sense out of it. I try to make sense out of what the neuropsychologist is telling me, what the imaging is telling me, what the patient is telling me, what the actual injury was, and then try to synthesize, looking at all of the data, what makes most sense for this patient? What do they really have? If you were to hang your hat on any one of these things, you may go down the wrong path. That's why I said yesterday, it's a team sport. You have to work with your neuropsychologist, your radiologist, your therapist to really get the best idea of what the patient has encountered and what you're going to do about it. You know, these white matter tracks, this is a picture that I got from Aaron Bigler at the University of Utah, who's spoken at the conference the last several years. And this is a beautiful shot of all of the different fiber tracks that are within the brain. And one of the points that Dr. Bigler made for us on several occasions is that just because you have a lesion in one particular part of the brain doesn't mean that another part is not affected, because these are all fiber tracks. They connect things. So example would be, my telephone line went dead. It's not because my telephone is bad, it's because the line somewhere in San Marcos went out. So you have to be careful that when you see injury in one particular location, for instance on a scan, it may not exactly correlate to all of the issues that the patient has because of these connections. It's a common pitfall. I wanted to end with talking about a newer technology that's been out for a few years now, but which I think has really started to graduate into what I think is useful. Magnetoencephalography. Now this is a form of EEG, if you want to call it that. Electroencephalography, you know, we put the wires on a person's head and then we record electrical activity. But that recording is through the scalp and through the skull. And there is a lot of interference and loss of information that occur as a result of those barriers. Magnetoencephalography, using this incredible machine, which I think costs a ton of money, it actually just looks at the magnetism produced by the brain waves. It has nothing to do with the skull or the scalp. It actually eliminates that as a barrier, and it can give us additional information. And this additional information can show up as slowing in the brain in one particular part. And in this particular image from Roland Lee at UCSD, which is where the majority of this work has been done, you can see some slowing on the right frontal area and compared to the left where you don't see that. Now this is non-specific. It may occur in a variety of other conditions like brain tumors, seizure disorders, and so forth. So you have to be careful. But in studies where you take individuals who have no medical problems whatsoever, for instance in kids or in the military, and young military patients, and you compare a control group to a concussed group, there are some interesting findings. You can also represent these in a different way by showing the parts of the brain, what we call the voxels, that show where the slow waves are occurring. And there are 4 patients here. And what you're seeing here in these yellow areas, the yellow areas represent what they call a Z-score of 6 or greater. That means that these are patients' findings that are equal to or greater than 6 standard deviations from the mean. Very significant. And so what you see here, these yellow areas, very interestingly, all show up in the cortical white matter junction areas, or in the cortical areas, which are the areas that we think brain injury is most predominant. So, oops, did I miss a slide? I did. So his data, Dr. Roland Lee's data from UCSD, indicates that this technique is 85% effective in detecting an abnormality in a concussed patient, and there were no false positives, which I think is quite interesting. And I can get the paper if anybody's interested in it. So I'm going to stop here and introduce our next guest. I will stop for a couple of questions. This slide says, remember the good old days when we played sports and never worried if we got concussions? No. So I'll take a couple of questions, and then I'd like to introduce our next speaker. Any questions? Yes, ma'am. Right over there. Let's wait for the mic.